All right, good. Thank you. So again, thank you very much for the invitation, David. I apologize for not being able to be there in present, which I would love to, but unfortunately, I got a little bit sick this past Friday, and I just couldn't make the trip. Some of you may have seen my presentation. I believe it was 3 years ago, about a project of building an artificial intelligence-based central decision supporting system in the local stroke network in Hungary. So this time, David actually asked me to demonstrate the development of acute stroke care in Hungary in general, and to give a summary of the achievements of that centralized AI-powered stroke imaging network, which aims to provide fast access to imaging results for all of the involved parties with an immediate image analysis and reporting using artificial intelligence, and a communication platform for all players in both the primary and the thrombectomy centers. All of this, of course, is in a small and medium population density country, which is by far much smaller than, for instance, what you have seen in Spain in the previous presentation, with a primary purpose to facilitate prompt and equal access to an effective treatment of acute ischemic stroke for all of the inhabitants of the country, regardless of the area of residence within the country for all people. So regarding the structure of stroke care system in my country, it goes back to the late 80s, early 90s, with organization of specified stroke centers starting in the mid-90s. Currently, the requirements for an accredited primary stroke center include a second-level department of neurology with the capacity for diagnosis of a CT scanner and potentially an MR for 24/7, having a neurologist on call 24/7, and having a stroke unit or access to ICU or emergency department, again 24/7, and being able to provide thrombolysis as a treatment option. The requirements for an accredited comprehensive stroke center, such as a thrombectomy center, besides on top of those that I presented for the primary stroke centers, include having neurosurgery department and a capacity, besides of CT and MR 24/7, and besides of the neurologist, having a licensed neurointerventionist, a neurosurgeon being on call 24/7, stroke unit, of course, and ICU with dedicated neurointensive services. And these centers would provide thrombolysis, thrombectomy, as well as decompressive craniectomy for ischemic stroke, but of course, all kind of treatment for hemorrhagic strokes as well. It may be worth of mentioning what is a licensed neurointerventionist in my country. So the training requirements for neurointerventionists it actually comes with a special competency license that requires a 1.5 to 2 year full-time training and is available for radiologists, neuroradiologists, neurologists, neurosurgeons, and invasive cardiologists, with a curriculum which is specifically tailored content-wise and length-wise as well for the different specialties that the physicians are coming from. Also important to talk about reimbursement. So reimbursement became available for thrombolysis since the late 90s and for intraarterial treatment since the year of 2000. At that point, it was available for intraarterial thrombolysis plus intracranial angioplasty with or without stenting. And in 2013, we modified this to be available for mechanical thrombectomy, besides of course, intraarterial thrombolysis that has existed at that point of time still, and intracranial angioplasty, again, with or without stenting. One important point is that unlike many other procedures in healthcare, there is no volume restriction, so the case numbers for both thrombolysis and thrombectomy is unlimited regarding reimbursement, which of course is unavoidable. Another important issue is having a national pre-hospital stroke protocol, and that is developed by the National Ambulance Service together with the National Stroke Society. That means that all stroke suspects are to be transported to a stroke center within 24 hours from symptom onset. A race score is used. Earlier it was the Cincinnati score actually. And patients with a race score equal or higher to 5 should be taken directly to comprehensive center. I wouldn't say that this actually happens all the time, but this is at least the rule of the protocol, and this is the tendency to follow. Now, regarding demographics and the National Stroke Care Network, the size of Hungary is 93 quadrat kilometers with a population of a little bit less than 10 million, with a highly variable population density, which ranges from as low as 50 to up to 200 in the central region and up to over 3,000 in the capital city of Budapest. Hospital admissions for all stroke events per year are counted around 40,000 per year. And that is being taken care of 32 primary stroke centers. The blue dots actually represent the primary stroke centers on the map. And on top, 7 comprehensive stroke centers providing thrombectomy 24/7, and another 2 out of these 32 that are capable of providing thrombectomies in 1 or 2 days per week. And those are represented by the red dots on the map. So our motivation for introducing the AI-powered imaging network system lies about what we have seen as a dynamic growth of thrombectomy numbers. These are the numbers beginning in 2015 and up to 2019. As you do see, it's a very high, almost 10 times growth of the case number. However, what we have also seen is that the thrombectomy, the mortality of the patients following thrombectomy kept growing as well. What you see here is in the blue line represent the 90-day mortality, and the red line is representing the 1-year mortality. The two curves are very, very parallel with each other, so we have good reason to believe that at least the majority of the people dying 1 year after the stroke did die somehow in relation to their stroke. And that has been growing up to 40%. Thinking about the potential reasons, we came to the conclusion that one of the potential reasons could actually be the uneven distribution of the stroke centers, and particularly the uneven distribution of the comprehensive stroke centers, resulting in the majority of cases transported by drip and ship, having a significant time loss due to long door-in, door-out time during the transportation, which we actually measured at 2 hours and 33 minutes at that point of time, which again was in the year of 2019. So the plan was to provide a high-speed diagnostic tool as a decision supporting system for each primary and secondary centers, which we found very difficult to arrange for all individual hospitals due to the lack of finances. And therefore, finally, we ended up building a centralized system which we could finance from central resources using an EU grant that was actually aiming to reduce disparities to access high-quality healthcare throughout the country, and that was the Human Resources Operative Program in Hungary. So the system that we have built includes 2 separate subsystems, such as the northeast system here and the southwest system here. This layer includes or serves actually 10 stroke centers, and the bigger system serves 28 stroke centers. This is what we have built, that 28 center system. But altogether, the two system covers 38 out of the 39 stroke centers of the country, so basically every stroke center that works in Hungary. How does it work? If a CT scan is performed in any of the primary stroke centers, such as for instance here, it is with a stroke protocol, it's automatically transmitted to a central teleradiology server, from where again the DICOMs automatically go to any of the four artificial intelligence servers, and the artificial intelligence process is being done, and the processed images, now it's only the processed images, go back the same way to the primary stroke center, but at the same time they also go to the relevant thrombectomy center where the patient would be further transmitted to if it becomes necessary due to a large vessel occlusion. At the same time, the processed images go to the cloud, and from the cloud it becomes available immediately either on a desktop computer, on a mobile telephone, again in both the thrombectomy center and the primary stroke center if any further transportation is needed. I'm sure that all of you are quite familiar with these artificial intelligence systems. Now, just very briefly to say that what we use is actually the Brainomics system. It provides a calculation of the E-aspect score, both visually and numerically. It actually provides an automatic large vessel occlusion detection and a collateral score, scoring the collateral circulation of the infected or the impacted hemisphere. It also provides an automatic evaluation of the CT perfusion study. And as I mentioned, the results are become available on the hospital PACS system, as well as by mobile telephone or desktop computer for any of the persons being on call for that particular patient. Beyond imaging, it serves as a communication tool as well, which is capable of collecting clinical data such as NIHSS calculation and so on, recording the time metrics. It actually gives a recommendation according to the existing guidelines, but to me, at least most importantly, it gives an automated message to each of the players, including in the primary and the remote thrombectomy center at the time the CT scan is done and it is processed by the artificial intelligence. So for instance, at any time a large vessel occlusion is detected, my phone would give me an immediate message on that. So of course we actually used the Brainomics system way before this large network has been built, but only in our hospital. So we were quite confident with the results, but now we had the chance to check the accuracy in much higher number. So the correlation between the AI and the human reading was checked in a total of almost 1,300 patients, including 360 native scans and 900 post-contrast scans. Those are patients who have been transported by drip and ship and had a CT angiography before transportation, but the CT was repeated because the transportation time was longer than an hour or the patient clinical status has changed. So what you see here is the E aspect in blue and the human aspect by red. You can see that these parallel each other quite nicely. Actually, the correlation ratio was 0.99 for native scans and a little lower, 0.84 or 85 for contrast scans, but it needs to know that the system is actually not designed for the evaluation of contrast scans. Regarding CT angiography, we checked that in a group of 500 patients with anterior circulation large vessel occlusion, and the CTA of large vessel automatic large vessel detection was 0.86 and the specificity was 0.9. Regarding the performance of the system, we found a very dynamic growth of case numbers. This is what we had since the beginning of the system, which was introduced in October 2022 until this last month. Actually, in the last couple of months, we are right around 2,000 cases per month for CT and a little bit over 1,500 for CT angiography. I come back to that a little bit later. So the total number of cases since the installation is actually exceeded 50,000 with a mean volume in the last 12 months of being around 2,000 per month. The ratio of CT angiographies compared to the total number of CTs actually has been growing, and now it actually exceeds 70%, which we believe is due to the easiness of it having the automatic evaluation that makes it easier for the small hospitals to do the and evaluate the CTA. Regarding e-stroke and the number of thrombectomies, the total number of thrombectomies has been actually 2,000 last year in 2024 for the whole country, so this is for a 10 million population. This is the increase of the number of thrombectomies. There was a highly significant increase since the introduction of the e-stroke network, which was in 2022, so somewhere around here, and you see the increase after that, which is actually this 2,000 thrombectomies in this should be 2024, of course, sorry for the mistake. So it corresponds to 5% of all hospital admission with a code of stroke, but 27% of all stroke cases that were reported with a large vessel occlusion code. So that's where we are regarding the number of cases that has been coded for the National Insurance Fund with a large vessel occlusion code. Regarding time and metrics, we actually managed to increase a little bit. So before stroke, for the time of the first call made to the ambulance until arrival to the thrombectomy center, we actually had an extremely long time of 3 hours 54 minutes, and that has been reduced down to 2 hours 41 minutes. This data is coming from our center only, so this is not necessarily representative for the whole country, which is a major hub that is doing over 700 thrombectomies per year in Budapest. I'm sorry if it was too fast. So do we have further tasks? Of course we do. As we have seen in the previous presentation as well, the case load is highly unequal. I mentioned already that our institute is actually doing over 700 cases. Last year it was 760 thrombectomies, and there are institutions doing only something like 20 or 24. You do see these numbers all around the country. We definitely do need new centers, mainly in the west and in the southeast of the country. And basically, this is the numbers and data that I wanted to present. But in conclusion, I would say that we, first of all, do have an extensive stroke center network, including 32 primary and 7 comprehensive centers, plus another 2 out of the primary centers capable of doing thrombectomies, 1 or 2 days a week. We do have an established reimbursement system for both IVT and mechanical thrombectomy. However, with the increasing cost, this might not be sufficient, so further improvement is needed in this regard. The 32 primary stroke centers, sometimes we believe that it might be actually too many. However, the 7 thrombectomy centers is too few, so this is probably needed to be corrected as well. The total number of thrombectomies is actually exceeded 25. It goes up to 27% for all large vessel occlusions that are coded with large vessel occlusion. How accurate this is a little bit uncertain, but still clearly there is room to grow in this regard as well. We also believe that the application of a central AI-powered stroke imaging system, which is serving all primary and secondary stroke centers, is feasible in a small country at least. And that system is professionally highly reliable. We did not have any systemic downtime in the two-year period since the installation. The system is being used very actively, the number of scans approaching the total number of reported stroke cases in the country. And there was a significant increase found of the mechanical thrombectomy numbers since the introduction of the system. And the total time from the first call to arrival into the mechanical thrombectomy center has been reduced by a little bit over 1 hour. So this is what I wanted to present. Again, my apologies for not being there in present. Thank you very much for your attention. And should you have any question, I would be very happy to answer if I can. Thank you again.